All right, so hopefully you can see my slides here. So thank you so much for having me today. Welcome everyone. Thanks for joining. All right, so let's delve in. Let's get started. All right, so just going to first start off with kind of the obligatory slides when you give a talk or when I give a talk on narcolepsy, and I will reference this in some of the subsequent slides as well. So the pentad, and I will go through this pretty quickly for you. Many of you hopefully know the pentad at a personal level. So what is the pentad? So basically just outlining 5 symptoms: excessive daytime sleepiness, cataplexy, sleep-related hallucinations, sleep paralysis, and disrupted nighttime sleep. So excessive daytime sleepiness, the first one, the foremost one. So according to our ICSD, that's the classification manual, need to have daily periods of irrepressible need to sleep or daytime lapses into sleep occurring for at least 3 months. It's subjective in nature. So as a clinician, it can be very difficult to define and differentiate this, and patients often will use and loved ones will use various terms. So it's challenging, even with a patient and loved one sitting right in front of us, in front of me. It can be challenging to really define. Cataplexy, so just to speak briefly on this, so cataplexy generally triggered by a positive emotion, typically, saying something funny, coming up with something witty to say, laughter will trigger that, most commonly in the legs, knees, arms, or in the head and shoulders. The duration is typically short, a couple seconds, certainly less than 30 seconds for most. And you can see the frequency there as well. Sleep-related hallucinations. So here's where, it can become challenging. Well, daytime sleepiness is challenging, but the sleep-related hallucinations, because it occurs in the general population. So oftentimes I'll see a patient that, oh my gosh, they have hallucinations or paralysis. Do I have narcolepsy? Do I need to get an MSLT? Probably not, actually. So about 10 to 40% of patients without narcolepsy may experience hallucinations. And there's a wide range in how it's defined, how these numbers are ascertained from study to study, but maybe about 30 to 80% of narcolepsy patients with narcolepsy report hallucinations and or sleep paralysis. And there's various terms to describe it, whether it's occurring at sleep onset or upon awakening. The sleep paralysis hallucinations can occur together. They do tend, and we're going to talk about this in a little bit when we talk about psychiatric comorbidities, but in narcolepsy, patients with narcolepsy, they tend to be visual hallucinations, a spider, a shadow, whereas in other conditions, they may be more auditory in nature. And awareness of the surroundings is preserved so that they might see a shadow or something in the room, in the corner of the room or something like that. And basically the stats are very similar for the sleep paralysis as well. But it's literally an inability to move upon as falling asleep or waking up. It's not, like a compression neuropathy where a patient is someone sleeping on their right side and they wake up and they can't move their right arm or something like that, aka Saturday night palsy. But yeah, so that's sleep paralysis. And then disrupted nighttime sleep, which we're going to actually, one of my concluding slides will reference this as well. And so there's no, this is a specific term that is for patients with narcolepsy. It's kind of like a sleep maintenance insomnia, and how it differs from that it remains unknown, really, not well defined. There's no subjective or objective scale for it, which is challenging because it's difficult to study, especially in a rare disease such as narcolepsy. It's an inability to maintain continuous sleep in the prevalence range here, again, wide prevalence range, 30 to 95%. But some of the objective findings on sleep studies might be frequent arousals, more wakefulness after a patient might falls asleep, frequent stage shifts going from a light stage of sleep to REM sleep or stage 1 sleep, et cetera, and a lower sleep efficiency. That's just how much sleep they're getting over the total time in bed. All right, so let's delve into the topic at hand. So comorbidities in patients with narcolepsy. So it's always nice to start off a talk from a historical perspective. So obesity, higher BMI in narcolepsy has been reported, at least in this study, per my review, since 1934. Daniels reported that up to 50% of patients might gain weight around time of disease onset, up to 45 kilograms. And probably that's one individual. That's probably more of an outlier, but it certainly makes the statement more impactful. So more recent data suggests that obesity is reported in up to about 42% of adults and somewhere around 60% of children with narcolepsy. I think that's the only time I mentioned children in this talk, but another thing is in children, they can also experience precocious puberty, early in onset. Some of the more typical symptoms that we see in adults might be lacking, such as, like I suggested, that there's a trigger for cataplexy. In early onset narcolepsy, there might not be a trigger for cataplexy. So this is really the study that caught my attention 10 years ago. Higher BMI and obesity, like I said, was noted back in 1934, and then it was a couple studies, early 2000s or so, kept on reconfirming this, replicating that finding, and many studies have replicated that finding now. But it was certainly like circa 2010 when this idea or notion that there's increased comorbidities in patients with narcolepsy came about. And so here, for example, in this study, and you can see that the number of patients in this study, patients with narcolepsy, was 320, and they were with controls. They were matched to about 1,500 patients. Always important to look at that in a study is what are the ends. And you can see these increased odds ratios. And so when I highlight these numbers, I try to keep it really simple. This is a 1.5 or 3 times increased risk of developing this condition. And I'm going to show some more odds ratios in a bit. But so anywhere between 1.5, 1.3, upwards of 3.27 increased risk in diseases of the digestive system, heart disease, that's one that really got our attention, upper respiratory tract infections, hypertension. So you can see these cardiovascular risks are here. And that was in 2013. And then I had an opportunity to participate in a larger study using insurance claims. And you can see, it went from 320 patients with narcolepsy to, 9,000 plus compared to a lot of controls. This was an insurance claims database, so that has its limitations. And certainly at the beginning, it just to be completely transparent, I was a little bit skeptical of the data, but it had already been replicated, Ohio's data from 2013 in other countries by Yenham et al. But this was a larger study. And so what you see here is this is all the different classifications. Every single organ system is captured here. And over on the right, you see these glorious odds ratios again. Every single one of them were positive. So every condition, every body system we looked at in this claims database, there was an elevated risk for these conditions in patients with narcolepsy compared to controls, except anything related to complications of pregnancy, childbirth, and then I think the other one is, the perinatal period. And on a deeper dive, it looked like patients with narcolepsy were not getting pregnant as often, as if I recall correctly, as an explanation of this. So there was a negative excess prevalence for pregnancy, and that's what drove this non-significant finding here. So this is really what got me started with my interest in this topic. And when I first saw it, I didn't frankly believe it. And so in the next few slides, I'm going to kind of walk you through down my thought process and gaining trust and confirming this data, believing this data. So what about, my first thought was, okay, well, maybe this is being driven by types of narcolepsy. Well, we looked there. Really, the prevalence of all of these comorbidities were the same, whether we were looking at narcolepsy type 1 or narcolepsy type 2. There were some little caveats here, but with respiratory diseases being more common, maybe in narcolepsy type 1, and perhaps diabetes and sleep apnea being more common in narcolepsy type 2. So pretty similar across types. So what about, this is a really good way to confirm these findings, what about diagnoses that require laboratory or some diagnostic test? Were those actually increased in narcolepsy compared to control patients? And sure enough, you can see these p-values that tells you that it's a statistically significant finding. And again, you see these odds ratios, increased risk of, say, stroke, 2.5-fold, heart attack, 1.6-fold, heart failure, you name it, requiring a coronary revascularization, a 1.7-fold increased risk. Even tracheostomy, 3.2-fold increased risk. So these are laboratory confirmed, which is important, especially when you're relying upon, with this data set, insurance claims. Really, what the doctor, the healthcare providers are clicking, and then administration submitting that for billing is where all this data came from. So another thought, and this is not that study, but this is another thought, and this is from Paul Yinam's group from 2013, is, well, what, maybe this is patients with narcolepsy as they're searching for a diagnosis, going from doctor to doctor, because there's this idea that there's a 10 plus, not idea, it's a fact, a delay, common, that there's a 10-year plus delay in diagnosis of narcolepsy. So maybe this data was simply just capturing patients bouncing around from doctor to doctor trying to find an answer. Well, this data looked at, and I love this design, Yina's group looked at 3 years before the diagnosis, the first diagnosis of narcolepsy was made. Unfortunately, it's a socialized healthcare system, so a lot of beautiful data is captured. And then they looked 3 years after the diagnosis. And so what do you think we'd find? Well, I thought maybe we would find many more comorbidities being diagnosed, because if you do more tests, you're ultimately going to get more conditions, more diagnoses given to you. So I thought you might see more diagnoses in the time leading up to narcolepsy, and then perhaps less after, right? The optimism, right, is that once they get the treatment, get the correct diagnosis, a lot of those other comorbidities kind of fizzle out. And that wasn't the case. So this theory and possible explanation for this data, these increased comorbidities, really didn't pan out. Patients with narcolepsy presented with higher comorbidities several years prior to diagnosis, and actually even higher thereafter. And I'm not going to walk you through these, but you can see here are some of the odds ratio. Here you can see what's statistically significant. And I failed to highlight this for you, but here it is after as well. Oh, I did highlight it in red here. All right, so we're going to jump back into the 2017 study. And what about some of the conditions that have already been reported more frequent in patients with narcolepsy versus controls? Again, an increased risk. One, notably, well, a couple here that I'll just walk through. Periodic limb movement disorder or restless legs, just in case there's someone out there that might have restless legs. It was a 9-fold increased risk, which might be related to treatment, narcolepsy treatment perhaps. But restless legs is a weird, funny feeling in the legs, urge to move. When a patient moves, it feels better. And there's this circadian rhythm to it, so increased symptoms in the evening hours. And folks that have restless legs, they do tend to kick more at night. And so that's periodic limb movements. So just because someone has a lot of leg kicking on a sleep test does not mean they have restless legs. So if anyone out there has been told, oh, you had a sleep study, you have a lot of PLMs, a lot of leg kicking on those electrodes that we put right on the belly of the shin, right on the muscle on the shin, the anterior tibialis. And so we can see a lot of twitching, but that doesn't mean someone has restless legs. You just want to make sure it's kind of a risk for it, maybe, that you want to delve in and make sure the patient does not have restless legs. Sleep apnea, why do we see this increased risk? Well, in order to do an MSLT, the daytime test that we use to diagnose narcolepsy, we have to do a sleep test. So maybe this is simply just that more of these folks were getting a sleep test and getting a diagnosis of sleep apnea. But this too has been replicated with several more studies. And so sleep apnea is more prevalent in patients with narcolepsy compared to controls. And then REM behavior disorder. So this is acting out dreams. So someone's dreaming of being chased, or they have this ominous figure coming after them, and they're defending themselves in that. So they're punching in their dream, and maybe they wake up and they accidentally, complete unawareness, accidentally hit a bed partner or knock a nightstand off the shelf, the nightstand, and so that's suggestive of REM behavior disorder. All right, so, and I'm going to come back to some of these REM behavior disorder and in a second, as well as the sleep apnea. But we're going to now look ahead. So now these findings have been seen in multiple studies. So once you get a significant number of studies that are kind of showing the same thing, or maybe some are showing it and others not, you do a meta-analysis. You combine all of those studies together and see what it shows collectively. And so to date, according to this 2021 study, 48 studies were included comparing patients with narcolepsy to controls. And this is what they found: increase in prevalence in obesity, diabetes, hypertension, and cholesterol problems. So the authors here kind of recommend, in response to this meta-analysis data, early screening of metabolic alterations such as diabetes, and also cardiovascular risk factors. And they even, and I'm going to talk about this later, they state that include ambulatory blood pressure monitoring, which I'll talk to you about in a bit. And they really promote lifestyle changes. So smoking cessation, smoking is more prevalent in patients with narcolepsy, sleep hygiene, exercise, etc. But the important point here is now this has been replicated so many times that it needs to be on the radar of patients and physicians, but it's going to be the patients and advocacy groups like Wake Up Narcolepsy, that, if you have a diagnosis of narcolepsy, teach your primary care doctor, healthcare provider about this, and ask for an annual physical. The 25-year-old with narcolepsy, comes in once a year to see their primary care, if that. Primary care doesn't know a lot about narcolepsy, so they might be like, you're fine. No need to do a blood test. But given this data, I think that it does justify or seriously considering, checking blood work and other ruling out other risk factors. All right. So what about, so this is, again, kind of confirming the data, and this is from 2014. What about utilization of healthcare resources by patients with narcolepsy versus controls? This is a little bit out of order, but you kind of want to, once you establish that there's increased comorbidities, are patients with narcolepsy utilizing the system more? And in short, they are. So you can see here a twofold increase in inpatient admissions, ER visits, outpatient visits, physician visits, twofold increased risk in annual drug transactions, which one might say, okay, well, that's just because of narcolepsy treatments. But in fact, yes, it was a much higher usage of narcolepsy drugs compared to controls, but also a 72% higher usage of non-narcolepsy medications. And perhaps those are being used to treat the comorbidities, perhaps. And an increased annual cost. All right, so I told you, I promised you I was going to get back to RBD. So why is this significant? Well, I already kind of described to you what RBD is: acting out with punching, kicking, yelling, screaming. And so I think this was first described in the 1980s or so. And what we found is that if you follow these folks with what's termed idiopathic RBD, we don't know why you have it, but you do. That's idiopathic. That if you follow them long enough, that they're increased risk of developing Parkinson's disease. So you could look at this and say, oh my gosh, patients with narcolepsy are at a 44, I think it was a 44 increased risk of RBD. Does that mean now I'm going to be at increased risk of developing Parkinson's? Well, so let's delve into that a little bit. So alpha-synuclein, all you need to know is just that is found in patients with Parkinson's disease, alpha-synuclein. And so this study looked at skin biopsies in patients, non-narcolepsy patients with RBD, and then narcolepsy patients with, I'm going to put in quotations, RBD. And great news, what this study reported is that 87% of the non-narcolepsy patients with RBD had this alpha-synuclein, whereas 0% of patients with RBD narcolepsy had these deposits. What's that mean? Well, since no deposits found in patients with narcolepsy with, quote, RBD, then likely not at the same risk of developing Parkinson's disease. So there's some good news, perhaps, to balance out the other comorbidities. Also, might there be a reduced risk for Alzheimer's? So in Alzheimer's, rather than the alpha-synuclein plaques, you see amyloid plaques in brains of patients with Alzheimer's. Well, great news, and this is probably needs a replication, but just to inject a little bit of positivity here, lower levels of amyloid in elderly patients with narcolepsy. This might suggest a reduced risk for progression to Alzheimer's disease, according to this 2019 paper. Another positive finding, and maybe this relates to the REM-related phenomenon that patients with narcolepsy report experience, but there's a higher creative potential in patients with narcolepsy. And and further supports a role of rapid eye movement, sleep, and creativity. Now, what were the symptoms that were tied to this increased creative thinking? Well, it was sleepiness, hallucinations, paralysis, lucid dreaming, the quote unquote RBD, but not cataplexy. So cataplexy wasn't tied to this creative thinking. Just thought that was an interesting report. So switching gears, so medical comorbidities, this all started being reported back in 2010. Now we have meta-analyses looking at this, so it's well accepted now. But psychiatric comorbidities, so similar. Back in 2013, this paper came out. Now, psychiatric comorbidities, actually, like even psychosis, going back years, has been reported in association with narcolepsy. But this was one of the first papers that really did a nice job of looking at everything. Now, these red highlights here are for conditions that did not have a significant finding. So what you see across all of these psychiatric conditions, that there's a twofold, fivefold increased risk of bipolar in patients with narcolepsy, 320 subjects, compared to these controls. And then similar timeline back in 2017, another study with a higher N, 9,000 patients with narcolepsy compared to controls. Again, you see this pattern, this emerging pattern in all of this data. You see increased odds ratios for all of these psychiatric mental illness conditions. Interesting. So this one also talks about substance-related disorders and increased risk of 3.5. Now, there is in the literature, mostly I think anecdotally based, but there's this idea that patients with narcolepsy, probably specifically narcolepsy type 1, that the lack of orexin or the hypocretin deficiency is somehow protective or decreases the likelihood for addiction, perhaps. So this goes against that, but perhaps this is more driven by narcolepsy type 2, not sure. So just some further details about this. So the frequencies of these conditions were similar between both female and male subjects, patients. Anxiety and mood disorders were most prevalent in the younger age groups. Important to remember as we talk about general population data and sleepiness. And so I highlight a couple of these, and I'm going to talk about the psychosis data here. Right here. So narcolepsy and psychosis. So there's data at least here, 2005, but even 1980s, I think we're having reports of this. And I'll actually start with my last point here. Is probably a lot of this remote data was driven by, potentially high doses of stimulants, because that certainly can trigger psychotic symptoms. And in one of these papers, the author suggested that perhaps modafinil and pitolisant are least likely to induce psychotic symptoms, though I think I've seen, or a colleague of mine has seen a patient or two that had modafinil induce some degree of psychosis. Again, we've already kind of alluded to, there's some nuances and differences in patients, the hallucinations in patients with narcolepsy compared to schizophrenia that I won't belabor here since we've already kind of talked about it. But the main thing is that with schizophrenia, I mean, there's delusions in schizophrenia. There might be in the literature a possible association may exist between early onset narcolepsy type 1 and schizophrenia. I think that was based on the, do I reference it here? The 2014 paper down there. But that requires replication. We just have not seen that replicated to date. All right, so again, right, so once we get enough studies that are reporting on a certain finding, we group all those studies together and we do a meta-analysis, right? So here's a meta-analysis on depression or depressive symptoms in patients with narcolepsy. So it included 13 studies, I think it was compared to what, like 48 studies or so in the other meta-analysis for medical comorbidities. And what they found was about a 3 to 4-fold increased risk of depression, depressive symptoms in patients with narcolepsy compared to controls. So the authors conclude that PWN should be closely monitored for these symptoms in early screening. But the authors do emphasize that the estimates across all these studies were inconsistent, and just like for all facets of medicine, we need larger, better, well-controlled, more controls studies to replicate these findings. So what are some of the other findings? Well, anxiety, more common in the younger individuals. I think I mentioned that already. Depression, more notable in female patients diagnosed with narcolepsy at an older age. And then another study more recently found that in the year prior to diagnosis of narcolepsy, approximately 50% of patients with narcolepsy underwent psychobehavioral treatments prior to diagnosis. So these authors conclude from this meta-analysis that must implement a multidisciplinary approach to both diagnosis and management of narcolepsy. All right, so really going to just take a hard right and switch gears, but I promise in the last few slides of today's lecture, just to kind of wrap it up and put everything together so you can see what I'm thinking here. So what's the stability of the MSLT findings in patients with narcolepsy? And it'll take a couple slides for you to understand my take-home point here. But the short version is that, in narcolepsy type 1, NT1, narcolepsy type 2, and idiopathic hypersomnia, when you do the MSLT again, it's pretty stable in type 1 narcolepsy, not as stable in type 2 narcolepsy, and maybe even a little less stable in idiopathic hypersomnia. So that's certainly a challenge. And so again, when I got interested in this area is just seeing patient after patient coming in with one MSLT that was positive for narcolepsy and another one that's not. And then also trying to make sense of this increased comorbidities, right? What was driving this? Was this narcolepsy type 2 just a marker of someone that complained enough and seek treatment, demanded evaluation and had an MSLT? Or what was it? So that's the take-home point there, is that the stability in narcolepsy type 2 and IH is not really stable. Now there's some serious limitations of these studies in the fact that they're all retrospective. Coming off of medications. Why was the test redone? Was the diagnosis at the beginning at hand in question? So there's a lot of limitations, but this is the data that we have to rely upon. So why are MSLT findings more unstable in narcolepsy type 2 and IH? I guess the short answer is we're not sure, but I just kind of outlined some of the potential explanations here. The last one is the MSLT has also been demonstrated to be positive in the general population. And so we're going to switch gears. Now it's going to be an abrupt left turn and talk about subjective and objective sleepiness in the general population data. Again, the goal here is just try to process this increased comorbid data, increased comorbid conditions in patients with narcolepsy. So this is general population data, not patients with narcolepsy. So I'm not going to read all of this line by line, but I just saw a recent report came out. Yeah, excessive sleepiness is rampant in the general population. If you don't add a frequency to it, maybe 30% of patients have in this epidemiologic study are complaining about sleepiness. If you go through and add different criteria, including frequency, and then after eliminating other sleep disorders, you come up with about 1.5% out of this sample of about 16,000 adults across 15 states would meet criteria for a hypersomnia condition. So what's the point here? Well, yeah, excessive sleepiness, again, I said it's difficult to put your finger on it, even though I'm sitting in front of a patient. Sometimes it's a common complaint, but if you drill down, you're only left with about 1.5% for hypersomnia conditions. And then in a couple other studies, in the general population, what are the predictors for excessive daytime sleepiness? And these findings, you'll see that there's some overlap of these findings with the comorbidities that are reported in narcolepsy, right? And we just alluded that the MSLT findings in patients with narcolepsy are not the most stable, aren't stable, but there's limitations of those studies. So it's potentially the EDS, the excessive daytime sleepiness, and this is a theory, is that really what's at hand? Is that the risk factor? Maybe it's not, narcolepsy itself, perhaps. Maybe it's just excessive daytime sleepiness as this new cardiovascular risk factor. But so what are the predictors? Well, depression was number one, and that was independent of medication use, and also was found to be more prevalent, more common explanation in the younger folks. BMI, age. So with age in the general population, up to like 25 years of age, you see an increased prevalence of subjective reports of daytime sleepiness, and then it dips into the 40s, 50s, and then increases in the 70s, 75-year-old individuals. Of course, subjective estimate of sleep duration. I say I don't sleep that much. Well, that's a predictor for daytime sleepiness. That's no surprise. Diabetes is another one here. Smoking, perhaps that's self-medicating. And then last but not least, I know many of you on the call or loved ones have experienced that, you see your sleep doctor and they just insist that it's sleep apnea driving your sleepiness. And this, at least in the general population, depression was well before that, and BMI and age, et cetera, before sleep apnea as a potential explanation for sleepiness. The point here with this little bullet point is that in the general population, yes, sleepiness is common, 30% or so, but 25% of those folks remitted. So it's spontaneously resolved. And in the literature, specifically for narcolepsy, idiopathic hypersomnia, there's this report that sometimes these conditions, just as quickly as they came on, they can spontaneously resolve. And so some folks, healthcare providers, take that notion and say, well, depending upon the symptom severity in the patient, we need to be careful and balance our desire to optimize treatment with the fact that, maybe this condition might spontaneously resolve if we just conservatively manage the condition. So that's a bit of optimism that at least in general population data for sleepiness, that 20% of them resolve. So what were the main predictors of remission and improvement in EDS in these studies? So achieving a normal weight, less hypnotics, that's interesting. Hypertension, which is interesting since I'm giving a comorbidity talk. Why does that? It was a signal for improvement in EDS in the general population. I don't know. Of course, increasing your sleep duration, that makes total sense. And less insomnia and depressive symptoms, of course, that makes sense as well. What about objective sleepiness? And when I say objective, I mean, how does the MSLT, the daytime test, right, perform in general population data? Well, about 6% of men and 1% of women, if they undergo an MSLT, it'll be positive for narcolepsy. Now, just like in narcolepsy type 2 and IH, this is probably a more unstable feature, but it's also an unstable feature. So just because a patient in the general population had a positive MSLT and 4 years later when they repeat, it might be negative and not support a diagnosis of narcolepsy. A very important point is shift workers. So it's important that sleep clinicians and healthcare providers really optimize and strive to optimize other conditions before just ordering a daytime test. So, for example, shift workers are 8 times more likely to have a positive MSLT. So, in this idea of shift work is one thing, but very common in society now, and I just saw a report that maybe 30% or so reported, is this concept of social jet lag. And I don't think we don't fully appreciate the implications of this, but this idea that we get through the week, right? Getting by with, whatever the number is, 6-7 hours, not enough sleep. And then on the weekends, we play this catch up. So there's this idea of social jet lag. And for some folks, when they do this catch up, right? So we think that we're doing the right thing. We're catching up on the weekend. Yeah, get more sleep. You can never catch up on sleep debt, but can at least try. But oftentimes for folks, that increased sleep duration on the weekends, they're doing it to get by during the week, right? To replenish the tank so they can get through the next week. But what night is the worst night of sleep for those folks? It often ends up being Sunday night. So what's really important, and this is way off topic, but I tend to do that, is that consistent sleep across the 7-day work weekend is really, really important to minimize the impact of social jet lag. And also, antidepressant use was 11 times more likely to have a positive MSLT. So why do I bring that up? And any of this is with antidepressant use, right? So if psychiatric comorbidities are more common in patients with narcolepsy, the test that we do is not perfect, but it's certainly our best objective test. And sometimes you're faced with patients that have both clearly, based on the data, have depression, but they're also excessively sleepy. And when they come in front of a clinician, we want to help, right? And so you have to weigh the risks and balances of potentially trying to perform that perfect MSLT where you withdraw or taper down the antidepressant against what that might cause, suicidal ideation or just worsening depression. And many patients just flat out say, no, I can't do that. But if a patient continues on an antidepressant, 11 times more likely to have a positive MSLT for narcolepsy. So is that noise? We have no data to help us interpret that test. So here's kind of the crux of the matter, right? So, when I gave this talk 5 or 6 years ago, before we had those meta-analysis, it was like most of the articles were kind of reading, here's another, or my impression was, here's another study showing increased risks. Now the articles are kind of, and reviews are really saying, okay, we must accept these increased risks, both in medical and psychiatric comorbidities. But now we're starting to ask questions like, what's driving those risks? And I've already kind of alluded to that excessive, maybe it's just excessive daytime sleepiness, both in the general population, it's increased, and maybe that's what's driving it. Maybe it's the narcolepsy type 1, the orexin deficiency itself that's driving these increased risks. So what's some of the data? So what my purpose in the next few slides here, as we get ready to conclude, is to answer this question, or no, not to raise possible explanation as to what is driving this increased cardiovascular comorbidity. So autonomic dysfunction in patients with narcolepsy is present, but the data is mixed. So some studies show it, others don't. So the heart rate in patients with narcolepsy type 1 is variable during wakefulness, and it's normal to high during sleep. Interestingly, heart rate changes associated with arousal. So if a patient with narcolepsy kicks in the middle of the night, typically we see an increased heart rate. So in controls, patients without narcolepsy would see a higher heart rate than in patients with narcolepsy, hinting at some autonomic dysfunction. Patients with narcolepsy, as you've seen, increased risk of hypertension. So they just have a higher blood pressure. Is it the high blood pressure that's driving these increased comorbidities and cardiovascular risks? Really switching gears, but instead of talking about human data, talking about animal data. If you inject or stimulate orexin hypocretin projections in animal models, you can see an increase in sympathetic nervous activity, which can then increase blood pressure and stuff. So maybe it's the narcolepsy type 1 orexin deficiency driving this, but that doesn't explain the whole picture, because like we talked about, right? Narcolepsy type 1, like type 2, we're seeing increased prevalences for these conditions in both of those conditions. So I promised I would talk about one of the studies I mentioned earlier. said that we need to, be monitoring and having patients with narcolepsy follow up, do annual physicals and stuff like that with their primary care providers and educating about these increased comorbid conditions. And one of the recommendations in that study, they even specifically specified it, including for patients with narcolepsy, to get a 24-hour blood pressure or ambulatory blood pressure profile. So let's spend a little bit of time talking about this. And the message here is, might this be one of the risk factors that's driving the increased comorbidities, the increased cardiovascular factors? So this picture right here. So normally when we sleep, what we want to see is about a 10%, 20% drop in our blood pressure when we sleep compared to when we're awake. And actually, a patient with a high blood pressure, or let's just say a normal blood pressure during the clinic visit, and then if they did a 24-hour blood pressure, they didn't see a drop in their blood pressure, that patient with a normal clinic visit blood pressure daytime, but don't drop their blood pressure at night, that patient's at a higher risk, cardiovascular risk, than a patient with high blood pressure during the clinic visit. But if you did a 24-hour blood pressure, that patient drops their blood pressure. Meaning to say that this dipping phenomenon, non-dipping, not dropping the blood pressure at night, is actually a stronger predictor for cardiovascular risk than an isolated, in the clinic blood pressure measurement or a home-based blood pressure measurement in the middle of the day, which begs the question, why aren't we doing this more? Not only in narcolepsy, but just in medicine in general. Well, I think it's access. It's a patient desire of wearing a blood pressure cuff for 24 hours, reimbursement. And, I don't know what the number is, but it takes so many years for findings and research to trickle into primary care and into medicine. So maybe it's that. But at any rate, non-dipping, not dropping the blood pressure is reported in patients with narcolepsy. Now, certainly this data needs replication and to have many more controls to compare against. But it does look like that patients with narcolepsy, they don't drop their blood pressure at night when they're sleeping. And medications, right? So there's no way that it's probably a multifactorial explanation, but certainly something we need to do a better job with over the coming years is, how do these medications, CNS hypersomnia medications, how do they impact autonomic tone, blood pressure, heart rate? Maybe that's causing exacerbating this non-dipping phenomenon, and then that's increasing these risks. So we certainly need more cardiovascular studies, more detailed cardiovascular outcome measures in CNS hypersomnia medications. Endothelial dysfunction. So think about the inside of our arteries. And this is, our arteries need to be able to dilate and constrict due to various stimuli. And inside of our arteries, our endothelium lining, the inner lining, that's responsible for or contributes to releasing factors that thicken the blood or make it clot more or thin more, et cetera, things like that. So that's what endothelium, some of the functions of it, a very basic explanation. So maybe that's the driver. Well, chronic sleep fragmentation, which, remember, disrupted nighttime sleep is one of them, is increased in narcolepsy. So maybe that is the driver here. It does show that chronic fragmentation does induce endothelial dysfunction. And there are some animal models for narcolepsy that show increased inflammatory factors. But now in animal models, at least hypercretin orexin injection may actually have a cardioprotective effect. So that goes against this. So it does not appear that endothelial dysfunction is driving this. And I got a couple more. Sleep apnea, right? We call sleep apnea is at a much higher risk in patients with narcolepsy. Maybe that's the driver of this increased comorbidity. Certainly not isolated risk, but potentially part of the picture. What are some of the other ideas? Well, we definitely alluded that it has been shown since the 30s, at least, patients with narcolepsy have a higher BMI, obesity. Might obesity, the higher BMI, be driving some of these risks? Patients with narcolepsy smoke, right? Smoking was a predictor in the general population for EDS. So that's probably self-medicating. That certainly drives these risks. And I already talked about this, but the medications we use, they have been shown to cause small increases in heart rate or blood pressure, alter cardiac conduction, and also putting less emphasis on the cardiovascular. Some of these medications can also worsen mood and anxiety. that we use to treat narcolepsy. So last two slides for Monica in Wake Up Narcolepsy. I'm finishing up here. So sleep disturbance, might this be a cardiovascular risk factor, right? Disrupted nighttime sleep is one of the pentat of narcolepsy. So in the literature, it's well established that sleep disturbances, especially not getting enough sleep, but sleep disturbances as a generalization, are associated with increased cardiovascular risk in the general population. So might this disrupted nighttime sleep be a cardiovascular risk factor? Well, we don't know. We really don't have an objective subjective measure of DNS, disrupted nighttime sleep, so we can't even begin to really ask this question or answer this question, study this question. So we need a better definition and criteria for disrupted nighttime sleep. So we can look, maybe it's the patient with narcolepsy with DNS that has an increased cardiovascular risk. I don't think we have any data on that. I already alluded to this. So this concept that excessive daytime sleepiness, maybe that's the risk factor. Maybe it's not the narcolepsy. I mean, certainly sleep disorders, sleep apnea, whatnot, are associated with EDS, but maybe it's just the EDS that's driving these risks. So remember, recall, excessive daytime sleepiness is common in the general population, and there's other studies. These increased risks vary from study to study, but this one paper by Lee et al. Here showed that there was a threefold increased risk for excessive daytime sleepiness in the general population, increase in cardiovascular mortality. And that's after they adjusted for more common risk factors, comorbidities. They even adjusted for sleep disorders. And they still saw that EDS drives an increased risk of cardiovascular comorbidities, mortality. And recall, positive MSLT findings do exist in the general population. And recall that MSLT findings in narcolepsy type 2 IH aren't stable. There's also, switching last point, conditions, but in sleep apnea, there's this emerging concept as we struggle to kind of understand the relationship between untreated sleep apnea and cardiovascular risk, and when you treat sleep apnea. But there's this notion now that requires further testing, but that if someone has sleep apnea and they're sleepy, those are the folks that are more at cardiovascular risk compared to a different pool of patients with sleep apnea that aren't sleep apnea. Again, this concept that it's the EDS itself, excessive daytime sleepiness, maybe regardless of cause, whether it's EDS and sleep apnea or EDS and narcolepsy IH, that's driving this cardiovascular risk. Or maybe the cardiovascular risk varies in severity by the potential underlying explanation of the EDS. I don't think we know. Last point here, after all of that, what are some of the challenges in diagnosing narcolepsy and narcolepsy? Well, our very criteria, right? So we just spent an hour almost talking about all the increased comorbidities in patients with narcolepsy. And so for narcolepsy type 2 criteria, the last bullet point in our diagnostic manual states that, well, the hypersomnolence and or the MSLT findings are not better explained by other causes, whether it's insufficient sleep, sleep apnea, delayed sleep, or effective medications. That's challenging. We just spent an hour talking about how all these conditions are increased in patients with narcolepsy. So this is a challenging statement. It's justified, but it's challenging as a clinician to abide by or figure out how to deal with this. So another one, this is for idiopathic hypersomnia, but insufficient sleep. So I think we can address this, right? The mantra is, sleep extension, define that optimal duration of sleep, consistent sleep before going in for the MSLT. So this we can address. For idiopathic hypersomnia, one of these other ones says hypersomnolence in our MSLT findings are not better explained by another sleep disorder, medical or psychiatric disorder. Holy moly, we just spent an hour saying how these conditions are so prevalent. So it's challenging when you really get into the weeds here and making a diagnosis of narcolepsy or idiopathic hypersomnia. Two slides. So what do we need to do based on all of this? Well, we need to evaluate, address, and strive to optimize all other conditions besides the narcolepsy, and then evaluate for CNS hypersomnia and narcolepsy, and kind of my new point is that what's good for someone without excessive daytime sleepiness is likely even better for someone with excessive daytime sleepiness. And so concluding remarks, medical and psychiatric illnesses are certainly increased in narcolepsy compared to controls. Now we had those nice meta-analysis studies, so I don't think that's really in question at this point. I think anything, now there is a publication bias, but any study you look at, I feel like it shows an increased risk in the condition they looked at. Subjective daytime sleepiness is common in the general population, which is a serious global health issue. The MSLT is not strongly stable feature in narcolepsy type 2 and IH, and it even can be positive in the general population. So you have a general population that's sleepy, the MSLT is not really stable in NT2, IH, which starts to lead is it just the EDS that's driving these cardiovascular and comorbidities? So I think at this juncture in time, so, like I said, 2010, that's when you started seeing these papers coming out on increased comorbidities besides obesity, higher BMI. And now I think we're at the point where we're asking the question as to what is driving that these increased risks. Is it the EDS, the excessive daytime sleeping itself? Is it the DNS disturbed sleep, potentially based on the reports from the general population data? Is it this non-dipping blood pressure profile, hypertension driving this? Is it the medications itself? Is it the disease itself? Is it the orexin deficiency that's contributing? And it's probably going to end up being multifactorial, and multifactorial is never truly satisfying as just one answer, one explanation. I have another point. And then, yeah, the diagnostic criteria, the challenge with the diagnostic criteria, given that all these conditions are so prevalent in narcolepsy, is just that you need to ensure that there's not a better explanation for the hypersomnolence and the MSLT findings. And so, yeah, here's my concluding remark. My last statement is that what's good for someone without hypersomnia is probably even more important for someone with hypersomnia. I think that's it. With
Dr. Rouff, excellent.
A few minutes to spare.
Yes, excellent. Thank you. Such great information. We do have 12 questions.
Deal.
You may have touched on them going through from the beginning. So first one, can sleep paralysis be confirmed or seen during the sleep studies? This person was, okay, great. This person was, let's see, okay. All right. Is there, I see there are many narcolepsy patients with connective tissue disorders, Ehlers-Danlos syndrome, and also I'm surprised to see that ADHD and ASD is not mentioned here. Both connective, I think that was before maybe you put the ADHD up. Both connective tissue disorders and developmental disorders are known to cause many autoimmune related symptoms. In Japan, the number of patients with ASD and ADHD are significantly huge in the narcolepsy population.
And ASD was autism spectrum?
Yes.
Yeah. So there is one study, I think, by YEH that showed all these showed that there is an increased risk, like 2.5% in patients with narcolepsy compared to controls for autism spectrum disorder. And certainly there's an increased risk of ADHD, concentration, learning difficulties are reported in patients with narcolepsy. I just didn't go, when I show some of these slides, they're huge organ systems with many diseases captured inside of those. So a lot of those very specific diagnoses are buried within there.
Mm-hmm. What is the significance of restless leg syndrome that is of concern?
I think I just went on a tangent there.
Okay.
I guess in the setting of patients for patients with narcolepsy, so oftentimes we might use an activating antidepressant or something like that to treat narcolepsy. And so antidepressants can actually exacerbate restless legs. So if someone out there with narcolepsy on treatment is experiencing restless legs, it might be the treatment itself that's causing the restless legs. So maybe you need to step back and say, maybe it's that antidepressant or some other med that I'm taking that's causing that, before piling on yet another med. So maybe they need to pivot and switch to a different medication. I guess that's the only way I could make it relevant.
Okay. Great point on the substance abuse disorder. While anecdotally there may be a decreased likelihood in narcolepsy type 1, these disorders have physical and psychological components. Do you encourage your patients to incorporate social support such as small groups and or therapy, CBT
Absolutely.
or mindfulness? Okay.
Yeah, absolutely. And so I thought that might come up to, the Wake Up Narcolepsy just had a brown bag with Dr. Ong and Dr. Harris. So certainly, it's multidisciplinary. So when that one slide talks about multidisciplinary approach, that means having, allied health workers, psychiatry, set up to evaluate and care for patients. And there's no doubt that life coping skills, small group support is incredibly important, both for patients, but also, loved ones, caregivers.
Okay. Great. Thank you. The definition of narcolepsy type 2 is only confirmed by the MSLT, but how can those people have such a low MSLT positive rate?
Low MSLT positive rate.
I think maybe in that graph.
Yeah, so it's just basically those studies have limitations, but it's all the data we have, and that the MSLT came about simply by, not simply, but noting that patients with narcolepsy, when they fell asleep, they would go right into REM sleep. And then we were finding that some of those, the MSLT criteria that was established for narcolepsy type 1, that we then found to have cataplexy, that there were patients without cataplexy that were also having positive MSLT. So then that's kind of a brief explanation as where narcolepsy type 1 and how narcolepsy type 2 kind of grew out of that data. So, I mean, the MSLT was kind of created for type 1 narcolepsy, and then it defined this type 2. But I don't know why it's not a more stable feature. Again, those are retrospective studies. Maybe it's the natural disease itself. Maybe symptoms wax and wane. Maybe it's that, this is a talk for healthcare providers, sleep docs, but maybe we're not performing that MSLT and preparing patients as well enough, or in a systematic approach, meaning that the conditions are standardized from one test to the other. Sleep deprivation can cause a positive MSLT. Like I talked about, social jet lag and things like that. Maybe that's what's creating the noise. Is just our societal decreased reliance upon sleep. So
Okay.
Those are all potential explanations of the data we have.
Talking again about the MSLTs, is it true that 22 to 30% of the general population tests positive with the MSLT?
6% of men and about 1% of women. So no, much lower.
Okay. What you had.
Now, if you look at mean sleep latency and number of sleep onset REM periods and stuff like that, what was the stat? 20%?
About 22 to 30%.
Certainly not positive for
Okay.
narcolepsy. No, 6%, 1%. So 3% or so.
There is a big long one. I'll save that till the end. What about the high sodium and Xyrem and BP? BP is.
Yeah, it's a really good question. We had the sodium and Xyrem. In general, it's somewhere around, I think, 2,700 or so grams, milligrams of sodium in there. And so that's a high salt load, and we're dosing it at night. And recall that idea, that notion of dipping or non-dipping. We really, there's some articles written, but just to be abundantly transparent, we don't know. There's no data, objective data using 24-hour blood pressure that I'm aware of, specifically looking at the Xyrem versus the low sodium salt version Xywav. So we don't know. And frankly, if you think about this, if EDS is the marker, the cardiovascular risk marker, or perhaps sleep disturbance, disrupted nighttime sleep, that's the marker driving these cardiovascular risks. Why then, by giving these oxybate medications, if it fixes the daytime sleepiness and improves the fragmented sleep at night, maybe that offsets any potential risk of the sodium load. And there's been studies showing that if you selectively deprive patients of slow wave sleep, that can actually increase blood pressure. Responses in sleep disturbance can cause non-dipping as well. And so, yeah, I could go on and on.
This is on a different medication. What kinds of risks do you see with taking medications that have been created to treat EDS, such as Sunosi and Wakix, if you were potentially misdiagnosed with narcolepsy, even if the medication has helped the symptoms?
Repeat the question real quick. My screen.
Sorry. What kinds of risks do you see with taking medications that have been created to treat EDS, such as Sunosi and Wakix, if you were potentially misdiagnosed with narcolepsy, even if the medication has helped the symptoms? Do you see any risks, I guess, with Sunosi and Wakix if you were taking them, but you were misdiagnosed with narcolepsy?
Well, that's, there's different approaches, right? So there's one approach where you get a diagnosis of narcolepsy and you want to offer that patient the best medicine possible, or you can rely upon some of that general population data I mentioned where maybe 25% in the general population, EDS spontaneously goes away. In epidemiologic studies now, that doesn't get down to the individual level, but we do see increased sleepiness reports in the younger folks, 20-year-old, and then it dips in the 40s, 50s, 60s, and then increases later in life. If the subjective objective EDS is a difficult topic, but if you're tracking your blood pressure and vital signs, all your laboratory work, your subjective EDS is dramatically improved. You've met the goal. You met your goal of fixing that EDS. I don't think by having a diagnosis of narcolepsy type 2, that somehow mitigates risks of these medicines. You're taking that medicine to treat a subjective symptom, right? That's why that this patient in hand presented to a doctor, hey, I'm sleepy. Then you do a test that's positive and supports a diagnosis of narcolepsy. That doesn't fix the problem. Then we give a medication that treats excessive daytime sleepiness in narcolepsy. I guess we would have to use some of these medications outside of narcolepsy to really get at the answer to that question. Mm-hmm. I think you just have to define the goals, mm-hmm. And make sure there's no risks with blood work, vital signs, et cetera.
Thank you. I know I want to be respectful of your time. There are a couple more questions here. Okay. How many sleep studies were done in the patients in the repeatability study to determine the true NT2 versus IH when evaluating stability of MSLT results to the group in their respective groups? I would say
one of those 30 to 100, 50 to 100 in each of those studies.
Okay.
Were included there.
Okay.
Yeah.
All right.
And the controls, and you also that's important to ask what the number of subjects mm-hmm. with NT1 or NT2, but also the number of controls. I don't. One of those is mine. I don't recall the exact number. Sorry.
Okay. Any data on sore or weaker muscles or longer healing of injuries for people with narcolepsy?
I know of no data.
Okay.
But looking at this comorbidity data, everything has an increased risk. So I don't know of any data there. But there is MSK. So there are a lot of reports, actually. One of those organ systems is MSK. There's a lot of increased prevalence comorbidity conditions in the musculoskeletal system.
Okay.
So there's something there probably.
All right. And that
specific symptom, I don't know.
Okay. And somebody's asking about inflammatory conditions with narcolepsy. Still no studies. Okay.
Yeah, I need more data. Some animal model data, but need more data.
Okay. If you stabilize wake periods in PWNs with treatment with pitolisant, are there studies that demonstrate improvement in disrupted sleep as well?
It's a general concept, not specific to pitolisant, but sometimes, patients are complaining about their nighttime sleep, the disrupted nighttime sleep. And the idea being that if some patients avoid naps, which like the Dickens, in spite of the insatiable urge somewhat insatiable urge to take one, they avoid it to improve the quality of sleep. They clearly say, if I take a nap, but my nighttime sleep is destroyed. So taking that, just anecdotal evidence, and also there's data to show that if you take a nap during the day, your slow wave power, how much deep sleep you get in the first bit, is actually dampened, decreased. So if you take all of that, if you together, by taking a medication to help keep someone awake during the daytime, they nap, are less sleepy, more active during the daytime, then maybe they sleep better at night. And I've had patients say that, yeah, that, you know, by taking this pill in the morning, I actually get better sleep at night.
Mm-hmm.
And maybe those are, I haven't looked at this, but maybe those are the ones that were taking naps previously, and now they're not needing that nap, or maybe it's much shorter or less frequent.
Mm-hmm. Okay, great. Somebody's asking if you can explain what you mean by low salt version of sodium oxybate.
So the Xyrem medication's been around since 2000s or so, right? It's the salt, the GHB molecule is attached to basically a salt, so it's the sodium version of GHB. And so that has been around for 20 years or so. So recently they have reformulated that with different cations, so the GHB molecules attached to different things, and not sodium. So I forget all of them, but potassium and some others. And so the low salt version now it has less salt. Potentially as an explanation of this, you know, action by pharma, you know, to potentially decrease, well, in general, you know, less salt, you know, we want to limit the amount of salt that we take for cardiovascular conditions and stuff like that. But there's no data, no head-to-head comparison between these two to date. Mm-hmm. It does make some sense, but there's no data. So there's a normal salt load and then a low salt version.
Mm-hmm. When treating IH patients with Xyrem, do we need to treat periodic limb movement disorder?
No.